Acute spinal cord injuries are traumatic events resulting in transient or permanent disruption to normal sensory and motor function, affecting up to 40 million people annually. Research into the pathophysiology of spinal cord injuries and its mechanisms have unlocked a multitude of potential pharmacological interventions. To clarify, there are different phases within the acute period that have vastly different impacts on patient outcomes. The primary phase, which is direct impact to the spinal cord, has not seen much innovation in research. Typically, surgical intervention to decompress the spine is the gold standard. However, the onset of the secondary phase occurs within minutes, but is most active in the 8 to 12 hours post-injury. Its main mechanisms include loss of cellular membrane around the lesion, resulting in high concentrations of calcium ions and rapid depolarization of cells. This triggers neurotoxicity with neuronal death and major inflammation. Preventing secondary damage to the spinal cord will cause a major difference in the quality of life for the affected patient, and this is what the upcoming therapies are aiming to target. First, let's talk about the neuroprotective pharmaceuticals. Excitotoxicity caused by excessive glutamate levels has major repercussions. Riluzole is a drug approved only for use in ALS patients in the US, but it has a neuroprotective function at the site of injury. It plays a significant role in glutamate inhibition and reuptake by astrocytes and can modulate the activation of receptors to enhance synaptic strength. This is done by blocking sodium channels, preventing that huge depolarization in cells. It has been shown to lead to improvements in neurobehavior, particularly in cervical injury, but phase 2 trials are ongoing. Methylprednisolone, or MPSS, is one of the most common therapies used for acute spinal cord injury. Lipid peroxidation occurs due to the cascade of oxygen radical reactions that occur due to the overabundance of calcium ions, causing cell death. MPSS is associated with neurofilament protein protection and increased impulse conduction. However, administration of MPSS has been highly debated by researchers, as its effects on injuries tend to be overshadowed by side effects such as GI issues and also increased risk of sepsis. It is typically only recommended within an 8-hour window from initial injury. NSAIDs. Research has shown that NSAIDs, including ibuprofen, can inhibit the activation of RhoA pathways after injury. These molecules are attributed to the inhibition of axonal regrowth, resulting in cellular death. Instead, NSAIDs inhibit intracellular RhoA signal pathways, allowing axonal regeneration and promoting sprouting of axons below the spinal cord injury, leading to a slight regeneration below the area. It's time for a speed round. The following all show promising effects of secondary injury, but have been unsuccessful or non-progressive thus far in clinical trials. Minocycline, an antibiotic that decreases apoptosis of neurons and oligodendrites and increases microglial activation. Ketorolac, an NSAID that inhibits cyclooxygenases, which reduces neuronal death. Magnesium acts as an antagonist for NMDA receptors, allowing cellular respiration to continue to prevent calcium inundation. There's also Cygen, or GM1 ganglioside. This promotes recovery in neurons and axonal regeneration, as gangliosides are components of neuronal membranes. However, this one has shown no improvement in clinical studies. Now, let's have a brief look at neuroregenerative drugs. The main one we talk about is anti-NOGO. The NOGO pathway sends inhibitory signals to the myelin of the CNS neurons, preventing growth. However, anti-NOGO aims to improve regeneration by interrupting the signaling pathway, and it has indicated an influence on angiogenesis, improving sensory and motor function in clinical trials. In terms of non-pharmaceutical therapies, neural stem cell therapies have become a center point of spinal cord injury research. These include embryonic stem cells and mesenchymal stem cells, which can differentiate into a range of neural cells, assisting in cord growth and regeneration. There are also oligodendrocyte precursor cells, which can help remyelinate damaged neurons. Mesenchymal stem cells have garnered particular interest as they can be harvested from a range of adult organs and tissues. However, a multitude of ethical and health-related issues have prevented mainstream studies of these therapies, including graft rejection, immunogenicity, and issues with long-term survivability. Altogether, it is clear that there is still a long way to go in terms of reducing the impact of cellular and molecular damage to increase the quality of life for patients. The ethical, financial, and therapeutic requirements mean that it may be many years before we see any meaningful change to spinal trauma interventions. Until then, I'm Kate Gallo, and this has been an update on acute spinal injury research.